course, in this presentation, we would have heard that PCOS is the most common which women.
Just a request, everyone, please mute yourself except the speaker.
So it is comprised of a variety of endocrinologic, metabolic abnormalities, including hyperandrogenism, insulin resistance.
Dr. Gunjan, please mute yourself, please.
Can I continue?
Yes.
Altered that leads to chronic
Dr. Gunjan,
anovulation.
please requesting you to mute yourself. Dr. Gunjan.
Muted, ma'am.
Carry on.
Okay. In the absence of adrenal and pituitary gland dysfunction, this is very important because whenever we get girl with PCOS and has hirsutism or has some kind of an abdominal striae, then we need to rule out, are we dealing with some adrenal cause? And one differential diagnosis, of course, is late onset adrenal hyperplasia. Now, what is the latest evidence in this? Is the Indian study, and which says screened in 688 women. 573 were enrolled, 281 urban, 292 from rural, and the prevalence of PCO in urban and rural areas of Hyderabad, Telangana was around 6.5 to 6.8%. So this is our Indian data on PCOS. So you can see that there is a little variation as low as 8% to about 22.5% in Veena Joshi's study. Now, getting into the mechanism, we understand the mechanism. It is easy to treat PCOS. So it all starts from, we understand that there is insulin resistance, and that is why there is no as such significant, reason to do an insulin level, because 60% of the women will be having insulin resistance. There is an abnormal lipid levels. We understand, if you can go back into the intrauterine life, why preterm children will be more prone for insulin resistance, because the brown fat theory is the fat which is good for the body, which is gained in the last month of the pregnancy. And if preterm babies are born, then later in their life they gain white fat instead of that brown fat, which was better for them. So increased insulin secretion basically increases the insulin-like growth factor 1, which is a pancreatic, growth factor. It acts at the ovarian level. It acts on the free androgens. There is hirsutism and acne. Then this excessive androgen levels will cause altered FSH-LH ratios, a decreased SHBG, menstrual irregularity. They'll end up in anovulation. Then there is an anomalous gonadotropin secretion, and of course there is a whole dysfunction of the HPO axis. And this goes on like a vicious cycle. So what happens in obesity? Enlarged adipose cells, so the capacity is exceeded. Then there is excessive deposition in the muscle, liver, high serum fatty acids which are elevated, and then there is inflammation. Now, the moment there is initiation of inflammation, the macrophages get attracted to the dystopic fat disposition to phagocytose these adipocytes. Increased release of adverse cytokines, there is tumor necrosis factor, and production of decreased production of protective cytokines. Now, this also could be explained that why slightly there could be an increased risk of miscarriages in PCOS women, because they have an altered cytokine levels and an altered TNF-alpha. How we read that, how progesterone helps in immunomodulating, in pregnancy the same way. Now, if we are going to diagnose, if you see the Androgen Access Society, then they take into consideration both the features. It has to be there, because the culprit is hyperandrogenism, which leads to ovulatory dysfunction. So how do we manage these patients? We have heard a lot. We will only be seeing 2 slides about the non-pharmacological management, and then what we know about metformin. So overweight people, of course, there is no doubt about it that lifestyle has to be the first line. Any reduction in 5% body weight can reduce the insulin resistance and testosterone levels, and can reduce the cardiovascular risk, and monitoring calorie intake, which we have already heard from Dr. Ritu. Now, what is the pregnancy outcome of women with PCO in IVF? Let's see what was the cohort study of about 7,600 women. And out of which 666 women had PCOS. This was done in 2017. So they had an unfavorable pregnancy complications, including miscarriages with an odds ratio of 1.6, and a very chance of preterm delivery, which is very preterm delivery, less than 32 weeks with an odds ratio of 2.07. So for pregnancy outcomes, of course, initially they were associated with higher pregnancy rate, but also higher miscarriage rate. So PCOS is associated with an increased risk of several pregnancy complications, which may include miscarriage, preterm delivery, even after adjustment for all confounders. And women undergoing IVF with PCOS, they need increased surveillance during pregnancy and parturition, and better understanding of pregnancy complication rates among PCOS women will reduce the risk of both obstetric and neonatal complications. So I think only folic acid, identify the risk factors, and improvement. Nothing can over supersede reduction of the body weight. Now coming to only metformin, the metabolic, insulin sensitizers, how it will work. It will work at different levels. It will reduce metabolically lipid synthesis, gluconeogenesis, increase the SHBG levels, reduce the glucose level. It will reduce the insulin levels, insulin-like growth factor 1, the androgens. Anti-inflammatory actions will be reduction in tumor necrosis factor and CRP. Anti-angiogenic factors, that is VEGF, will be reduced. Anti-carcinogenic, it will be reducing the insulin and IGF-1. So there are so many multiple levels at which, metformin can work. So number one, it will reduce the hepatic glucose production. It can have an anorexic effect. It increases the insulin sensitivity, reduces gluconeogenesis, suppresses inflammatory cytokines, suppresses adipogenicity, and favorable effect on glucose and lipid metabolism. Now let's come before pregnancy, since I am in the ART field. So let's see what Cochrane had to say, that is there any benefit of metformin during IVF cycle or ICSI cycle? Basically, the question was metformin and versus placebo, and we could see that when it just comes to IVF outcomes in terms of ovarian response or embryo formation, well, there was not much in favor of metformin. You can see the diamond was close to the central line. So there were some studies more in favor of metformin, some were equivocal, but overall they did not make much of a difference when it came to metformin usage. So what was the 20 years of ovulation induction with metformin? The best possible evidence that metformin cannot be recommended as a first-line pharmacological treatment for anovulatory women, but very recently Ashray has said that you can start metformin, but still in our clinical practice, if you ask me, yes, I do not use metformin as a standalone agent. I may combine it with an ovulogen, but yes, in our armamentarium, letrozole has become the first line. Now, it does not improve the efficacy of clomiphene as a first step treatment for ovulation induction. Available evidence is insufficient to recommend as a primary treatment in non-obese PCOS women. Then clomiphene cannot be considered an effective option in patients with CCR PCO. No evidence exists of reduced spontaneous abortion risk in PCO who have undergone pre-gestational metformin treatment, and no evidence exists of increased risk of major anomalies in women with PCOS undergoing metformin treatment during the first trimester. Now let's go and see that what happened to metformin treatment before and during IVF ICSI in women with PCO. So this was a forest plot. Again, there was not much of a difference, though a little, all the studies were slightly favoring metformin versus placebo, but ultimately it was kind of not that statistically significant. So coming to Ashray, what does Ashray have to say? These are the 2018 guidelines. They said metformin, in addition to lifestyle, could be considered now in adolescent with a clear diagnosis of PCO or with symptoms of PCOS before the diagnosis is made. So this is one change. Maybe this will also help in a little weight reduction. Then it may offer greater benefit in high metabolic risk groups, including those with diabetes, risk factors, impaired OGTT, and high risk ethnic groups. So impaired OGTT we have always been giving it. Now, where the metformin is prescribed in the following, which needs to be considered. See, important is adverse effects. GI side effects can be there. So start with a low dose, 500 milligram, increment it every 1 to 2 weeks, and you can use extended release instead of an immediate. Now, the use of metformin appears to be safe long term based on use in other population. However, ongoing requirement needs to be considered and use may be associated with low vitamin B12 levels. And yes, when I was going through the literature, they said that keep monitoring B12 levels, and especially in patients with chronic renal disease, the dose of metformin needs to be titrated, and do not give very high doses because there is a risk of course, more lactic acidosis. So off-label health professionals need to inform women and discuss the evidence, possible concerns, and side effects. The next it said, which was a high level recommendation, that of course healthy lifestyle behaviors, they have to be the most important part, and we cannot overcome that. And the lifestyle has to be a multi component which includes diet, exercise, we heard a lot, and 5 to 10% weight loss is the initial beginning weight loss which we need. So the routine use of metformin before and or during ovarian stimulation is not recommended in GnRH antagonist protocol for women. So please understand that earlier there was a lot of data saying that it prevents ovarian hyperstimulation syndrome, but that was in the era when we were using agonist protocols where HCG trigger had to be given, so it was a good molecule. Now with the usage of antagonist cycles in almost all the cycles, especially in hyperresponders, we have the flexibility to give agonist as a trigger, which produces minimal or negligible chance of ovarian hyperstimulation. And that is why use of metformin just to prevent OHSS has gone, and there is no recommendation for that. So if we see in this chart, metformin still I would consider as a second line if you are using letrozole or clomiphene as the first line. And of course, third line has gone surgery. Gone are the days where we are doing ovarian drilling. So this is one. The second way you can see that to reduce the insulin resistance, yes, you can use first line like in menstrual abnormalities along with lifestyle modification. So you categorize your patients into three groups. One with overtly altered OGTT, give them. Those who are trying to lose weight, not able to lose weight, yes, metformin can be given. Obese PCOS, yes, metformin can be given. As a second line, in addition to ovulation induction, yes, letrozole can be given. Metformin can be given, and this is how you can categorize your patients, and you can give metformin even in adolescent patient. Now just few slides about metformin and pregnancy and what is the data. They have an increased risk of pregnancy complication. 2011 meta-analysis showed odds ratio for different pregnancy complication, which is definitely increased in PCOS patient. A 3 to 4 fold increase in PIH, preeclampsia, a 3-fold increase in gestational diabetes, and a 2-fold higher chance for premature delivery among PCOS patients. So what the authors concluded that as such hyperandrogenism, obesity, and insulin and the other metabolic abnormalities basically contribute to increased risk of obstetric and neonatal complication, which are more associated to PCOS than PCOS in itself. So women with PCOS have shown placental inflammation, placental thrombosis, and infarction during pregnancy, added to villus immaturity and nucleated fetal red blood cells. So these alterations may be signs of vascular damage and fetal hypoxia, which could be linked to complications in PCOS pregnancies. So metformin has been evaluated in several studies in the context of PCOS pregnancy, and it was reported that 18.7% incidence of miscarriage in non-treated patient versus 10% in women who received metformin up to 32 weeks of gestation, and no, there were none patients in who received metformin throughout the pregnancy. But then going to 2012 meta-analysis, they said that reports in 5 out of 7 studies analyzed, metformin reduces the development of GTM in pregnant women with PCOS. As the methodologies were different and there were no RCTs at that time, the results were inconclusive. The biggest and more accurate RCT regarding this issue was performed by Vanke et al., and their work showed no effect of metformin on the prevalence of gestational diabetes and preeclampsia, and only a significant reduction in preterm delivery in a subgroup of compliant patients in per protocol analysis. And that is what, ever since this, we have been kind of following it. A second RCT 2019 from the same group reported a reduction in the risk of late miscarriages and preterm birth, but no difference in the prevalence of gestational diabetes. The effects of metformin on preterm delivery are of notable interest given the known association of preterm delivery with neonatal mortality, respiratory distress syndrome, cerebral palsy, GI and cardiovascular disorders, retinopathy of prematurity, and high cost related to prenatal care, among many other consequences. So metformin use is able to normalize the androgens, the insulin levels during pregnancy, reduces the AMH levels and ovarian marker associated to be a higher risk in PCOS in the female offspring as early as 2 months of life. So this was just one slide which I brought in, that what will happen to the neonates. And study carried out in Norwegian children born to women with PCOS receiving 2 grams of metformin daily from the first trimester to delivery showed that women who use metformin in pregnancy lost less weight and their infants were heavier than those in the placebo group 1 year postpartum. So that sums up my presentation. And so basically I want to say that yes, metformin I do not use in all my PCOS patients. I have my certain limited indications, and I will just stop sharing. And then I'm open for discussion. Thank you so much. And thank you, Shada ma'am, Dr. Shalini. This is a wonderful forum, very, very enthusiastic and very keen. So I also, heard the previous presentation and it was very interesting.
Yeah. Thanks, Dr. Shweta.
Yeah, looking forward for your participation more and more. Thank you very much.
Absolutely.
Yes, ma'am. Dr. Sujata, all the experts, please.
Thank you, Delhi Gynae Forum, Shadajan ma'am, and organizers for giving me this opportunity. And Dr. Shweta, it was very nice presentation. I just want to add 2 things. In our country, where most of the people they are living in village and tier 2 city, metformin has definitely got a role, because insulin sometimes is difficult to take in pregnancy. Then we can continue safely metformin, as you have already mentioned. And if the PCOS patient is already on metformin, we should not stop it if she gets pregnant.
Yes, yes.
And it helps sometimes in weight reduction by making insulin resistance normal. So if patient is doing everything not able to reduce weight, we can add metformin and see. So these are the things which I want to add.
I also think that, when people are going on weight reduction and they're not able to, because this ping pong phenomena is there in PCO. So adding metformin at least helps them a little weight reduction of about 4-5 kgs, 3 to 4 or 5.
Yeah, especially it helps in obese patients, metformin, and in reducing the weight, it helps there. And
yes, I tend to agree with Dr. Shweta, is that people who are a normal weight and who do not have earlier menstrual irregularity, as a policy matter, gone are the days when we used to use metformin 100% cases.
Actually, the common GI side effects are very high on metformin. Acceptability is not that much. So I would be, yes, judicious in using any of the molecules. And myo-inositol, because it's a nutraceutical, so I personally don't use it. The inositols, yeah.
Yeah, myo-inositol and Cairo, in fact, they say they has to be there present in a particular ratio. 1:40 or 1:80 ratio, all these company people recommend. And if that ratio is not there, then probably it is not that effective. And vis-a-vis metformin, I think we all prefer metformin because this is tried and tested.
See, I just was doing my OPD. Very interesting. This girl comes to me. She was awaiting embryo transfer, and she says, "You've given me, HRT, and my my endometrium is so thin." She says, "I'm going to just start exercising. I know the moment I start exercising, next cycle, natural cycle, my endometrium will be very good." I said, "Yeah, we always promote that. It causes increased blood flow to the pelvis." She says, "Nothing doing." She cancelled her cycle. She said, "I will come on my own in the middle of the cycle next time, and you will see my endometrium." So we it's lifestyle. It just comes back
Yeah.
to lifestyle, to most of the things, and especially to PCOS, because there is no permanent solution to it at all.
Yeah, very true. Very true.
I just want to ask one question. It's
Yeah,
just came in my mind. Suppose there's a lady with pregnancy, with altered GTD, with very bad history of previous miscarriages, preterm, and gestational diabetes. Is any role of metformin in these patients besides diet control during her current pregnancy?
but if our sugars are elevated,
Yeah,
Mhm.
her 75 grams.
so
Uh,
I've always on insulin,
Yeah.
no,
always.
insulin everybody cannot take. Like, well, as I said, in poor country,
But
we have
if
a
our
poor
levels
country
are
and
if our
small
levels are so
cities, they cannot
altered,
monitor their
yeah.
blood sugar level so closely, and it's difficult to take so many injections.
See,
So,
I am in the practice
No,
where
Dr.
every patient of mine
Sujata,
takes
one thing is
insulin.
clear.
Yeah.
One thing is clear. It all depends upon your monitoring. If you
Mhm.
find your monitoring is great, you can go on with metformin. If the monitoring shows that your blood sugars are exceeding between
Yeah.
120 to 130 as far as 2 hours meal is concerned, then you have to add on an insulin, which is much safer.
Yeah, that is much safer, and moreover, she already had a bad outcome last time. So, if you guide the patients that insulin corrects the sugar levels very well and much better than the metformin, then I think this patient should be on insulin rather than on metformin.
Another thing, I think Brigadier Sharma is here. He will be able to comment it. That as far as Brigadier Sharma and myself are concerned, I feel that unless things come in guidelines, please do not use the drugs. This is I'm talking in particularly about the myonisitol. I think I will
Yes.
like Brigadier Sharma. I don't use it in my practice, so I will ask Brigadier Sharma to comment on it.
I think Dr. Dhanmi had some question to ask. Let
Yes,
her
Dr.
ask first.
Tarini and Dr. Alka Jain. Dr. Tarini, you first.
Dr. Sharma, you carry on first.
Okay, okay, thank you, ma'am. Uh, no, madam is right. One need not start the drug just because it is being promoted left and right. We have to select the patients where we would like to give metformin, and where we would like to give minoxidil. So basically, a patient who is thin and hirsute, then I may be able to to increase the androgen levels. I may give the this thing combination of minoxidil and decanoxidil. But a woman who is obese, there I would prefer to give her metformin rather than giving minoxidil. So that we have to differentiate between them. And as far as metformin, earlier we were giving to every woman, who was even diagnosed or undiagnosed as a PCO. But now we are very selective. It's only when there's an insulin resistance where you would like to give the metformin to these patients. And rest, the diet and all the exercise, that is a part and parcel. So it is not one thing that is going to help these ladies. So we have to have composite. And something very interesting I just want to share with you all. You know, in army there is a big competition to rise in the rank, and one of the criteria for that is that they should all be slim and trim. So I have seen during our college day and even the busy practice, we all put on weight. But once you have to, compete for the brigadier and above, you must reduce and come into the shape. And all of them, they use metformin to reduce the weight, and they all come back with the exercise. So this I have seen. So possibly metformin along with the exercise can help. This has helped many patients also. Metformin with exercise can help them to reduce weight.
सर आपने ये आर्मी की बात बताई. There is a big study going on in US, 3 million were normal people who do not have any kind of problems. They started with metformin, and the equal number is in the placebo. And again, this is a trend over there. If people who want to remain slim and thin after 45, they are on metformin.
Even when semaglutide is used,
Sam,
everybody
yeah.
uses semaglutide
But-
in USA for weight reduction.
So I just can I add, ma'am?
Yes, Dr. Tahini,
Dr.
ma'am.
Shada ma'am, thank you so much, Delhi Gynae Forum and Shada ma'am, for this opportunity and excellent presentation by Dr. Sweta. I just wanted to add, I saw the Cochrane review. Now these days we should not use metformin as left right as it used to use, because there are so many complications as a gastric, if a gastric intolerance. Moreover, in the many these days with the pollution of the food or adulteration, there's a, so we should not use. Problem. We have to select the patient. Suppose the patient is not ovulating with the ovulogens, then we in that resistant patient we can add the metformin. And for the, as Dr. Sujata, you were saying the miscarriages repeated. So there are clear-cut guidelines. There is no improvement in the obstetric outcome of maternal and neonatal. So we have to be very judiciously if we should not use the metformin or not. So there is not much role of the metformin in the pregnancy for the obstetric or neonatal outcome.
Yeah, ma'am, I was saying in those
Moreover,
patients
one thing more,
who
like
stop.
in the pregnancy, suppose the patient is not like responding to the medical nutrition therapy, so patient has to be on the insulin. Now, usually we give the insulin.
Yeah, maybe Dr. Sujata was saying from that point, maybe in the rural areas where they don't have access
Yeah,
to.
definitely, many people are using.
Yeah.
As ma'am saying, there is a study in the US, the people are taking for becoming the slim trim.
So the bottom line is better to use insulin to control the blood sugar levels with the monitoring and to avoid any unforeseen or any bad obstetric outcome. Insulin still stands as the first rule. And Dr. Gunjan? Dr. Gunjan was the chairperson.
One thing is when we are putting the patient on insulin,
Yes, sir.
hyperglycemia is slightly better than the hypoglycemia. So we must teach them, what are the symptoms of hypoglycemia, so that otherwise they may sleep off and they may not get up in the morning because of severe hypoglycemia. So if they get bad dreams, if they had sudden sweating or palpitation, they must always carry. So this education also is very important, because the pregnant woman as such can have this type of symptoms, and which get aggravated if they go into hypoglycemia. So we have to educate them if they're putting them on insulin, that be careful that if you have these symptoms of hypoglycemia, immediately take some sugar.
Sir, Dr. Sharma, also there is a, from the many patients they develop lactic acidosis from the metformin. So we also have to educate for that also.
Yeah.
As you rightly said, the education is very, very important for pregnant women and otherwise also.
Yeah. More so for the pregnant woman, because the growing fetus is taking away the nutrition all the time. So she is likely to have more hypoglycemic spells in comparison to other ladies. So that we have to educate them. So as the Dr. Sujata mentioned, it may not be possible in a rural background. So under those circumstances, there will be a place of giving metformin rather than insulin to this patient.
Anybody
Dr.
who wants to make
Yeah.
any comment last minute?
Yeah, ma'am, I have one question to Dr. Shweta Mittal. Dr. Shweta?
Yeah, I'm there.
Yeah. Dr. Shweta, suppose a patient walks into your OPD where you find, she was just given metformin, maybe empirically, and because we know there is so much overuse of metformin, and you actually feel there was actually no need to metformin. So in those patients, would you continue metformin? If yes, still how long, or would you prefer stopping
No,
it at
I
3
normally
months?
stop metformin, because if I feel that what she needs is an ovulogen, then I will just start. So if she's like known PCOS girl, then I would look for a data where she has been given any, ovulation induction. If not, I will start with that. Number two, I will also look at her menstrual cycle, abnormality. What is the length of the cycle? Higher the deficiency, more would be the treatment. And then I will look at whether she's lean PCO or she's obese PCO. So, my normally my decision is to, if I don't see any other reason, then I go on ovulation induction
No, that I
rather
mean.
than just banking
मुझे
on
फोन बज
metformin.
रहा है.
Yeah, ovulation induction you have given. Like she was already being given metformin and now she is conceived. So you would
Okay,
continue the
then I
entire
continue. Then
pregnancy?
I send her to the endocrinology department also once, and we kind of look for GDM early onset rather than getting an OGTT done later. I would get done
Yeah.
earlier because I want to identify those people who would go on early insulin. So that's my aim.
Yeah, that's a very important point that
Yeah.
these patients
And
should
I
be
would encourage her to
screened
keep
for
a glucometer at home and check every week her fasting and postprandial sugar. So this is what I do.
Yeah, that's a great point. And any other questions or Shada ma'am, your comments
Hey,
so that we
Shalini, wind up, wind up.
Yeah.
Oh, yeah. So we all had very excellent talks and
Thank you
been
so much.
excellent. Yeah, Dr. Shweta, Dr. Ritu, and sincere thanks for joining our forum and presenting the talks. And sincere thanks to all the faculty members, Sharda ma'am, RK sir, Dr. Vandana, Dr. Jyoti Bhaskar, Dr. Tarini, Dr. Sujata, and I guess Dr. Gunjan probably has left. And Acha, Dr. Gunjan is there. Yeah, Dr. Gunjan, any last 1 minute comment? Want to hear from you?
Yeah, no, it was wonderful and thanks for inviting me. After a long time, I have attended Delhi Gynae Forum and it's a pleasure and I always feel nice seeing Sharda ma'am there. बड़े दिन बाद आप दिखे.
Great.
On
And
this
Dr.
particular
Bhuvneshwar ma'am.
forum, once in a month we have on infertility and IVF, and now we find that nearly 75 to 80 people are usually joining it. Your patronage probably makes this particular forum more successful. Any younger person wants to make a presentations, please you should get in touch with Shalini and
Sunita.
Dr.
Yeah, okay. So with this,
Dr. Sunita.
we wind up this session and looking forward, as Sharadan ma'am said, anyone interested can get back to us. And we look forward to your presence again next month, 20th of every month. We do this.
Thank you.
Thank you. It's been a pleasure. Good evening, sir.
Thank you, ma'am.
Thank you, sir. Thank you, sir.
Very nice session and very nice talks.
Very interesting, yeah.
Good.
Excellent, very knowledgeable, very
Really
knowledgeable.
enjoyed it.
Thank you so much.
Come
Thank
back
you.
again.
Shweta
Come back
ma'am.
again.
Thank you, Shweta ma'am.
Dr.
Thank you.
Rajvi has raised a hand. Dr. Rajvi.
No, I just wanted to say thank you. It was very nice.
Okay.
Dr. Shalini, your talk was very nice.
Thank you so much. Thank you
Good.
so much.
All the talks were nice. Dr. Shweta's was also very, very.
सिर्फ प्रॉब्लम ये है कि जो वेजिटेरियंस हैं वो क्या प्रोटीन खाएं, मैं तो यही सोचती रह जाती हूँ.
एक बार टॉक कर लेंगे इसी के ऊपर.
मैं वेजिटेरियन प्रोटीन इन वेजिटेरियन करेगा.
Madam, here I wish to tell you that the new guidelines of ICMR and National Institute of Nutrition has come. I will send you the link in chat box of infertility in IVF. And please, it is 147 pages thing. You must get a copy done and read from first word to the last word. You will be knowledgeable. Please.
Great.
I will give you the link.
Sure, ma'am. Sure, ma'am. Please share the link. Okay.
Dr. Sujata,
Thank you so much.
Vegetarians कोई hypoproteinemic नहीं है. ये मान के चलो.
अरे बाबा लेकिन वेट कैसे कम करेंगे, बोलते हैं हाई प्रोटीन खाओ, हर चीज में तो
Ma'am, we will have a talk on this. We will have a talk on this. पहले उसको वो it is as latest as 8th of May this year. So आप उसको पहले पढ़ो और पढ़ने के बाद फिर डिस्कशन करें. ठीक है?
ठीक है.
ठीक है मैम.
Thank you.
That's a great idea. Thank you, ma'am.
Thank you, Shweta ma'am. Thanks, Dr. Vandana. Thanks.
Okay, bye-bye. Bye-bye.
Bye.
कल आ रहे हो ना डॉक्टर शालिनी?